So good evening, everyone. My name is Suyog Sathe. I work as a director and regional manager South Asia for the International Gaucher Alliance. I welcome and thank you all for joining today's virtual CME on Lysosomal Storage Disorders, which has been jointly organized by the International Gaucher Alliance and Sanofi Genzyme. The objective of this CME is to shed light and create awareness amongst the healthcare professionals about the challenges and priorities with respect to LSDs from the perspective of South Asia. So to share insights on this crucial topic, we have with us today Dr. Ashok Vellodi as the esteemed speaker, who is a former consultant pediatrician at the Metabolic Unit of the Great Ormond Street Hospital, UK, and is also one of the most renowned experts globally when it comes to lysosomal storage disorders. Also moderating this session, we have Dr. Madhulika Kabra, who is a professor at the Division of Genetics, Department of Pediatrics, AIIMS, New Delhi, who is also one of the leading genetic experts in India. So with this, I would now like to request Dr. Madhulika to take over and lead us through this informative session. Over to you, Dr. Madhulika.
Thank you, Suyog. Good evening, good afternoon, good morning to everybody, depending on the time zone where you are from. Welcome to this virtual CME on lysosomal storage disorders. At the outset, I would like to thank International Gaucher Alliance, Suyog and Tanya in particular, for inviting me and giving me this opportunity to moderate this very important session. Which is focusing on South Asia. So this would really give us some important insights regarding LSDs in this particular region. Lysosomal storage disorders are a group of about 50 different disorders, which are individually very rare, but collectively they become common, and they have very diverse phenotype. They're likely to be seen quite commonly in pediatric practice and identified as well because some of them have got a very typical phenotype which makes them identified easily, and also many of these patients would live long and come in contact with a pediatrician. The challenges in the developing world are many when we talk of rare disorders, and particularly when we talk of disorders like lysosomal storage disorders. This is related to the awareness amongst the healthcare professionals and the public, though I must say that it has certainly improved over last 5 to 10 years. It is very important to have an early suspicion and diagnosis, and there may be a problem even if somebody suspects. There may be a problem in getting access to the diagnostic facilities, particularly in some parts of the world. And it is needless to say that early diagnosis and management, may it be supportive also or specific, is the key to managing these disorders. Specific treatment is available for few of them, and unfortunately is extremely expensive, and that is the major issue in particularly in countries like India and other countries where this access to treatment is the major problem. Supportive therapy, as it is important for most of the disorders, is available but also needs strengthening because you need experts in these particular disorders, because the kind of supportive therapy these patients need may be different from the routine supportive therapy which you give. So, and very, very importantly, prevention is the key. So, if you identify one child in the affected in the family, there is a possibility of making a specific diagnosis and providing prenatal diagnosis in the subsequent pregnancies, particularly for very severe disorders for which treatment is very expensive or not available as of now. So, to sort of shed light on this particular area, we have Dr. Ashok Vellodi, who would be speaking on lysosomal storage disorders in South Asia, focusing on the challenges and priorities. He is a very, very well-known expert in the area of lysosomal storage disorders, as Suyog just said. And he was a formal consultant pediatrician in the Metabolic Unit in Great Ormond Street Hospital for Children, NHS Foundation Trust, UK. He actually did his MBBS and MD from India, MBBS from Pune and MD from All India Institute of Medical Sciences, from where I also work presently. He's MRCP, FRCP and FRCPH. He has the membership of very renowned societies like British Medical Association, Society for the Study of Inborn Errors of Metabolism. He has membership of international organizations, like he's a chairperson of the task force on neuropathic Gaucher disease in the European Union, and he's a member advisory board of European Cerezyme Access Program. Additionally, he is the recipient of IAIM Oration Award and also Alan Gordon Memorial Award of the UK Gaucher Association. So apart from his these renowned academic achievements, I would, on a personal note, I am highly thankful to Dr. Vellodi for his support and guidance, which he has been providing for managing our children with LSDs in India. He is a member of the INCAP, which is the Compassionate Exit Program supported by Genzyme, and we have had several clinics with him in our own hospital and got his valuable input for our patients. He has been instrumental in teaching us and our residents through his lectures, particularly in the area of lysosomal storage disorders. So for today's talk, Dr. Vellodi would be touching on the lysosomal biology, pathogenesis of lysosomal storage disorders, the clinical assessment, which is extremely important in these patients to make a diagnosis, the current treatment options with emphasis to South Asia, and the healthcare challenges, and how we can use the present opportunities and how we can prioritize management of these disorders in South Asia. So over to you, Dr. Vellodi, and we are looking forward to your talk, which is always has been very, very informative. Dr. Vellodi, please.
Thank you, Dr. Kabra. Thank you, Suyog. I'd like to begin by thanking the IGA for inviting me to give this lecture, and to Sanofi Genzyme for their support in organizing it. This is the first time I'm giving such a lecture, and so I wasn't quite sure how to pitch it. And I have really tried to focus on the problems in South Asia, drawing on my experience over the last few years, and really focusing on the clinical diagnosis and management. So these are the countries that we're referring to: Pakistan, Nepal, Bhutan, Bangladesh, India, Sri Lanka, and the Maldives. Having said that, my personal experience extends to only 3 countries. Apart from India, I have visited Pakistan twice and Nepal once. So my apologies in advance for not being really familiar with healthcare conditions in all the countries equally. As Suyog and Dr. Kabra mentioned, the CME objectives are lysosomal biology, pathogenesis, clinical assessment, current treatment options with emphasis on South Asia, healthcare challenges and opportunities and priorities. So let's start with lysosomal biology. The lysosome is one of the organelles of the cell. As you can see, there are many such organelles, but we're focusing today on the lysosome, which was discovered by Christian de Duve in 1955, and for which discovery he was awarded the Nobel Prize in Physiology or Medicine. The lysosome has 2 layers. It has a lipid bilayer, which is the outer layer, and a thick inner glycocalyx. And inside that, it contains the lysosomal lysosomal enzymes. Apart from the lysosomal enzymes, there are also lysosomal membrane proteins, which form part of the lysosomal membrane, and they have different functions. The lysosome itself is maintained at an inner acidic pH by various mechanisms. This is very important for lysosomal breakdown of waste products. So there are many functions of the lysosome, but the main function is to break down intracellular and extracellular waste. So there are two prerequisites for the lysosomal breakdown. The enzymes need to be transported to the lysosome, and the waste products need to be transported to the lysosome. Now here you have a diagram showing the transport of the enzymes to the lysosome. All lysosomal enzymes are proteins. They're glycoproteins, so they're formed in the endoplasmic reticulum. They move through the Golgi, and I won't go into details, but there is a pathway by which they effectively move to the lysosome. There are three pathways for transport of intra and extracellular waste to the lysosome: autophagy, endocytosis, and phagocytosis. And all of them ensure that the eventual target organ, the lysosome, is reached. As I mentioned, the lysosome has many other functions, and here are some of them. This is just for information, really. You can read this up. And I won't go into this in detail, but over the last decade, it's been very clear that the lysosome is far more than a simple garbage bag in which waste products are broken down. Now, the basis of LSDs, you can have defects at any of the points that I showed in my previous diagram. And according to the specific defect, a disease occurs. So you have the genetic defect, the protein defect, the storage, and the secondary effects on intracellular processes. And the effects on intracellular processes, there are several. These are all secondary effects on autophagy, oxidative stress, inflammation, lysosomal signaling. These are just a few. And eventually, these result in apoptosis, cell death. However, all intracellular processes are tightly regulated. Most of them are closely connected and interdependent. And so the secondary effects don't occur in a simple linear fashion as was suggested in my previous diagram. In fact, it's far more complex, as you can see in this diagram, and all these processes connect up with each other. And this is important when it comes to treatment. Lysosomes are ubiquitous, and therefore the effects of their storage are widespread. The distribution of lysosomal enzymes, however, is dependent on cellular and organ requirements. So some lysosomal enzymes may be more prominent or more abundant in the kidney, others in the brain, etc. And this also determines the effect of deficiency. So you have different types of storage. Here you have lipid storage, glycolipid storage, glycogen storage, glycosaminoglycan storage, etc. And each of these results in a particular set of lysosomal storage disorders. And because the storage is very cell and organ specific, the effects of the storage are also quite specific. So you can have specific involvement of the liver and spleen, the bones, the facial bones, the brain, kidneys, etc. And depending on where the storage occurs, this determines the clinical features of the disease. So let's move on to clinical assessment. Now, these are two figures from Australia and India looking at the prevalence of lysosomal storage disorders. Both were generated around about the same time. And you can see that there is a difference. So, for example, in Australia, Gaucher disease was only seen in 14%, whereas in India, it was seen in 32%. MPS in Australia was 34%, MPS in India, 20%. So now this may reflect different things. It may simply reflect the fact that different diseases have a different prevalence in different countries, or it could relate to underdiagnosis of certain conditions. And we'll talk about that later on. Now, if you look at the population of South Asia, it is over 1.8 billion, which is just under 25% of the world's population. Having said that, the total number of known LSD patients is probably less than 1,000. And you don't need to do the maths to realize that this number should be far greater. Now, in 2015, there was a paper from Mamta Muranjan's group in Mumbai, which looked at the need for early diagnosis. They looked at patients referred to their clinic. 532 patients were suspected to have LSDs. These comprised 9% of the total genetic cases. 335 were lost to follow-up, died, or did not complete evaluation. That's a huge number. LSDs were ruled out in 78 patients and confirmed in 2% of the genetic referrals in 119 patients. Now, they looked at I've chosen 4 key parameters that they looked at: the interval between the onset and suspicion, onset and presentation, onset and diagnosis, and presentation and diagnosis, and looked at the median interval in months. Now, when we come to the interval between presentation and diagnosis, the median interval was just 1 month, which is very similar to what one sees in Europe or the US. And this shows actually that once a patient is referred to a specialist center, the diagnosis is made very quickly. Sorry, by presentation, I mean presentation at the specialist center. However, the delays really occurred between the onset and presentation and onset and diagnosis. And the median was over a year. So really, this is where the delay, the bottleneck was. The group identified several issues: poor awareness, leading to delays in initial workup and referral, an increased risk of further affected children. Obviously, if you haven't made the diagnosis in the index case, then by the time the diagnosis is made, further affected children may have been born. Poor access to centers. Many of these patients came from long distances. Low motivation, illiteracy, poverty, lack of treatment. Very often, if families see that there is no treatment available, they won't come again to the clinic. A lack of diagnostic facilities. So these were some of the issues identified. So clearly, there are certain requirements on the part of general practitioners and general practitioners. There needs to be a high index of clinical suspicion and an awareness of clinical lab investigations. This the Mumbai team identified. In India, very few referring pediatricians start the laboratory investigations that are required. They simply refer the child to the clinic. Whereas in Europe and America, you will find that over 50 to 60% of patients have had their workup started even before they are seen in the specialist center. And this is an important difference. So let's talk about clinical presentation. There are many ways in which LSDs present: hepatosplenomegaly, coarse facies, dysostosis, neurological deterioration, non-immune hydrops, cardiomyopathy, angiokeratomas, psychiatric symptoms. Now, I'm not going to go into all of these in detail in this talk. I'll just touch on a few of them. So here's a patient with obviously a very enlarged spleen, in whom you might suspect a lysosomal storage disorder. These are 3 children presenting with varying degrees of neurological involvement with very different diagnoses. The child on the left has type 2 Gaucher disease, child in the middle has eye cell disease, and child on the right has GM1 gangliosidosis. They all presented in the first year of life. It can present with, this is another presentation, a cherry red macula. There are 2 important things to remember about a cherry red macula. The first is that it becomes less obvious as the disease advances. Okay, so it's most obvious in the early stages of the disease. And very often children, certainly I've seen in clinics in India, they present at an advanced stage of the disease and there's no cherry red macula. That doesn't mean that there never was one. Also, the macula is not always cherry red. So here you have 3 children. On the left, you have a cherry red spot in Tay-Sachs disease in a Caucasian child. Excuse me. In the middle, a Canadian Aboriginal child with a cherry brown spot, Sandoff disease. And on the right, an East Indian child with a cherry black spot, again, Sandoff disease. Angiokeratomas can be a clue. Here you have angiokeratomas in the umbilical area and the lips. These are seen in Fabry disease. Fabry disease, you have other important early manifestations, especially ocular ones, corneal verticillata and tortuous retinal vessels. These can often be the presenting features of Fabry disease. Sanfilippo disease, whom some of you have seen, is very easy to diagnose in the child on the left, who is obviously severely disabled, but the child on the right was totally asymptomatic. And this is not unusual in Sanfilippo disease. They present with early features such as recurrent upper respiratory infections or just unusual behavior, which is passed off as normal. And by the time they get to an advanced stage, quite often, and are diagnosed, further children, affected children, would have been born, and that was the case with the child on the right. By the time she was diagnosed, along with her identical twin, 2 other children had been born in that family, and all 4 were affected. Morquio disease, it's very visual, but unfortunately it's often misdiagnosed, either as rickets or skeletal dysplasia. So you can imagine with a child, an adult on the right here, how difficult it would have been to make the diagnosis. In fact, the only reason a diagnosis was made in her case was because her X-rays were seen by somebody who knew what they were looking at. Her sister had been examined and X-rayed, and she was thought simply to have spondyloepiphyseal dysplasia. Here's another presentation. This is a 16-year-old girl who was being followed up by the local rheumatologist for arthritis. She was referred to the ophthalmologist as standard workup for rheumatology. Corneal infiltration was found, and a diagnosis of beta-galactosidase deficiency was eventually made. And then on questioning, she told us that she had always been last in egg and spoon races in school, that she had great problems with her handwriting. She couldn't finish written tasks, and she had to be given extra time in lessons, but nobody thought that these problems might be related to the underlying lysosomal storage disorder. Acquired sensory neural deafness in a child should always be considered pathological unless proven otherwise. This child was initially referred to us at the age of 4. Sorry, not to us, he was referred to his local pediatrician at the age of 4 with a sensory neural hearing loss and was simply given a hearing aid. He presented at the age of 8, as you can see, has profound neurological disability, and in fact he had a diagnosis of metachromatic leukodystrophy. It is possible that had the diagnosis been made earlier, a bone marrow transplant might have helped. Having said that, not only was he beyond a bone marrow transplant, but he had by this time an affected younger sibling who was also too advanced. Acquired squint, again, acquired squint in a child should always be considered pathological. So this was a 3-year-old boy who developed lower respiratory disease and was treated as tuberculosis. He developed a squint. This was thought to be a side effect of treatment, but his parents then got worried, brought him to our center, and a diagnosis of type 3 Gaucher disease was made. So in his case, both the lower respiratory disease as well as the squint were secondary to his Gaucher disease. Here you have 2 pictures of the same child. The only difference is that the picture on the left, the right, shows profound central cyanosis. He has MPS 1H, Hurler-Scheie disease. Now, if he presented to the clinic without you having seen him earlier, you may well have missed the cyanosis. Similarly, this child whom I saw in one of the clinics that I did, as you may not be able to see from here, but again, she has marked central cyanosis. She has Gaucher disease. So the question is, why would a child with Gaucher disease develop central cyanosis? And how do you test? What test do you carry out? There is a very simple bedside test called the hepatojugular reflux, which many of you will know, but I've very rarely seen it actually applied in clinical practice. These are simple things that can be done at the bedside. So we should have algorithms, and here's an algorithm for the assessment of a child who presents with dysmorphic or skeletal or cognitive impairments, or combination of these 3, where you would consider an MPS-like disorder. And you have various pathways which lead you to specific diagnosis. And it is important to have these pathways because here are 3 pictures of children who look sort of similar. They have a slightly dysmorphic facial appearance, but in fact, they have completely different diagnoses. The one on the top has Hurler's disease, MPS 1. The one on the bottom left has MPS 6, and the one on the bottom right has MPS 2. So it's important to have systematic algorithms for the sort of approach to the diagnosis in these patients. There is far too much reliance on investigations such as bone marrow examination. And here you have 2 pictures, one of Gaucher disease showing the wrinkled silk cytoplasm, and Niemann-Pick type B showing the sea blue histiocytes. Now, this is all very well, but in practice, unless these slides are being looked at by experts, Either they're missed completely or the wrong diagnosis is made. I've seen Gaucher disease diagnosed as Niemann-Pick on bone marrow and vice versa. There's an over-reliance on X-rays. So here's a picture of a 13-year-old girl referred from somewhere else. The diagnosis of Morquio disease was made radiologically, and the reason she was referred was that she had raised intracranial pressure and needed a shunt. But we looked at her and felt that the clinical picture was not consistent with Morquio. You can see that she is blind, she has corneal clouding, she has a tracheostomy indicating airway obstruction. And so we retested her and we found that she had MPS 6, which clearly has a very different approach. So the confirmation of diagnosis, by and large, in South Asian countries should, in fact, in all countries, should be enzymology if there is a suspected enzyme deficiency. This should be the test of the first test of choice. Molecular genetics for membrane protein deficiency and diagnosis of female Fabry patients. Now, the problem is that in many centers in South Asia, laboratory measurements of enzyme cannot be relied on. The laboratories are unreliable, and therefore molecular genetics is resorted to. But there are pitfalls in enzyme diagnosis. For example, beta-glucosidase level, this is the enzyme that's low in Gaucher disease, they can be low in Niemann-Pick type C.
So anyway, you've looked at a patient you think you might have Gaucher disease, but you have to approach this systematically. So you've got a child with hepatosplenomegaly or splenomegaly, and the two commonest conditions are Gaucher and Niemann-Pick. If there is neurological involvement, it could be either type 3 Gaucher disease or type C Niemann-Pick. If there's non-neurological involvement, it's either type 1 Gaucher disease or type B Niemann-Pick. Now, if in the absence of neurological involvement, it can be quite difficult. See, these two children look identical, but the one on the left has a Niemann-Pick type B and the one on the right has Gaucher type 1. But if you look at the points, and there are a lot of features in common. If you look at the points down on the right, many of them are common to both, but there are two that distinguish the two. So in Gaucher disease, bone disease is more common, whereas in Niemann-Pick, lung disease is more common. Of course, that is not a barn door, that is not a definitive way of distinguishing, but it helps. When it comes to the neurological forms, we look at the eye movements. We look at the horizontal saccades in Gaucher disease. You put two fingers in front of the face and take them slowly apart, and you can see that he is looking from one finger to the other. He's blinking. I hope you saw that. That is the abnormal horizontal saccades. This is a patient with Niemann-Pick C. His horizontal saccades are perfectly normal. But when it comes to vertical saccades, you can see they're very abnormal. The vertical saccades initially are normal in Gaucher disease. Here we have another pitfall in diagnosis, enzyme diagnosis. Here's a child who was referred, and he looked like an MPS patient, and he was found to have a deficiency of the MPS 2 enzyme, which is iduronate sulfate sulfatase. But we felt that he was rather more severe than a typical MPS 2 patient, and further sulfatases were checked and found to be deficient. This leads to a diagnosis of multiple sulfatase deficiency. So essentially, if you have a child in whom you find a sulfatase that is deficient, you must check at least one other sulfatase. Otherwise, you will miss this diagnosis. There are lots of pitfalls in molecular diagnosis. The most common is finding a variance of unknown significance. So you have a child, you think you've got the diagnosis, you carry out molecular genetics, and you find a mutation. But this mutation has not been reported on before, and you are really unsure what the significance is. These are known as VUS. And there are different ways that you can carry out more sort of sophisticated tests. And this has developed over the years from Sanger sequencing, and then with the development of the Human Genome Project to other more sophisticated modern sequencing processes. Newborn screening is available for many conditions: Krabbe, Gaucher, Pompe, some MPS disorders, Fabry, the Niemann-Pick disorders A and B. But and this is just my own view, is that newborn screening may not be appropriate if treatment is not easily available. That has to be one of the criteria for newborn screening. Now, in South Asia, newborn treatment is not easily available. It's very expensive. So the question is, why would one want to carry out newborn screening in the first place? If you throw up a diagnosis, then what are you going to do about it? And cohort screening may be more appropriate. So what is cohort screening? So for example, in Fabry disease, hypertrophic cardiomyopathy, end-stage renal disease, stroke in young males, when you screen these cohorts, you will find Fabry disease patients amongst them. You have a very high chance of finding them. Similarly, when you screen limb-girdle muscular dystrophy, you have a good chance of picking up late-onset Pompe disease. As in this young adult with late-onset Pompe disease who, along with her brother, presented as limb-girdle muscular dystrophy. So let's move on to treatment. Again, I'm not going to go into detail, but basically there are different ways in which you can target your treatment. Therapy is reducing the biosynthesis of the substrate, or therapies restoring enzyme activity. And there are different types of treatment that have been developed over the years. Most of you have heard of enzyme replacement therapy. And this is a diagram of enzyme replacement therapy in Pompe disease. And it's very straightforward. The enzyme, the commercial preparation known as Myozyme is administered intravenously. It enters the cell via mannose-6-phosphate receptors and targets the lysosome. Once it's there, it breaks down glycogen that has accumulated. However, it is never as effective as endogenous enzyme. And the reason for that, well, there are many reasons, but one of the reasons is this. Now, here's a diagram of Fabry disease. In a normal person, in an unaffected person, the enzyme that's deficient, alpha-galactosidase A, reaches the lysosome having been produced in the cell. So it requires specific types of receptors which are available in the cell. But when you give the same enzyme from outside, then it's a very different story. You have to have a different set of receptors, and you have to ensure that the cells that you are treating have those receptors. We touched on lysosomal membrane proteins. Lysosomal membrane proteins result in a number of LSDs, such as Niemann-Pick C, MPS IIIC, Danon, cystinosis, and Salad disease. But as you can appreciate, since these are not lysosomal enzymes, they cannot be treated by enzyme replacement therapy. So other forms of therapy are required for these conditions. Now, the other problem is that secondary events have usually been triggered by the time the diagnosis is made, and therefore no single treatment is 100% effective. And they are also closely connected and interdependent, and therefore combination and tailor-made therapy is likely to be the most effective approach. As shown in this cartoon, where you have all these types of treatment on the outside, they've been written on the outside, but you have to tailor them according to the needs of individual patients or groups of patients. No one treatment is going to be 100% effective. What we don't really appreciate is that non-specific treatment is absolutely crucial to outcome. So here are some examples. In Morquio disease or MPS IVA, you have cervical spine narrowing, and this requires specific management with a halo. Cervical stabilization must be performed before the onset of neurological signs, and many children with Morquio in South Asia present with neurological signs and symptoms. Sadly, by then it's too late for stabilization. MPS patients have airway problems, and a wide variety of approaches is required and needed. So the anesthetist has to be aware and skilled in all these procedures. Carpal tunnel syndrome. It's important to know that this may be asymptomatic and should be looked for routinely. It's also important to know that occasionally it can present with an acute, painful hand. Here you have a child with a suspected swallowing disorder undergoing a video fluoroscopy. This is at Great Ormond Street. It's a joint investigation. It's carried out by the speech and language dysphagia therapists and radiology. So note the emphasis. Many speech and language therapists are not trained in the assessment of dysphagia. This is very important. So, as I was saying, there needs to be much more emphasis on non-specific treatment, and this requires a multi-specialty approach with various hospital specialties required: the LSD team, orthopedics, spinal orthopedics, neurosurgery, respiratory, just some of them. But coming back to ERT, there are global compassionate access programs. This is the Takeda one, which has just been published. You can see that they provide treatment for Fabry, Hunter, and Gaucher. And in Gaucher disease, so this shows you the duration of treatment with many patients now having been on treatment for over 5 years. I just want to briefly mention biosimilars. A biosimilar is a product which is similar in terms of quality, safety, and efficacy to an already licensed reference biotherapeutic product. And it's a slightly older chart, but this is a global biosimilar chart. And you can see that India has been a leader in producing many biosimilars. Unfortunately, I'm not aware of any biosimilar for an LSD that has been manufactured in India yet, or in any other South Asian country. And this may be a way forward. We also need to think about whether BMT is becoming a more attractive therapeutic option. So here's a chart showing the survival status of patients that undergone BMT at my previous hospital by year of procedure. So you can see that on the left, the BMT was done in 1981. The survival was very low, but over the years, the survival gradually improved. And this paper, published in 2015, showed very high survival figures, both overall as well as event-free survival. So it might be that BMT is a more realistic option in many patients. So here we have a bone marrow response in Gaucher disease to BMT, and this is the bone marrow pre-BMT, and this is post-BMT, and you can see that the Gaucher cells have been completely cleared, and the large white circles are fat globules. Similarly, you can see that there's a good biochemical response on the left with good enzyme levels, and the chitotrioxidase activity comes down to normal. This you will not see on enzyme replacement therapy. Here's a child who had a fracture of the neck of the femur, and with no other treatment other than BMT, it was healed 1 year post-BMT. So BMT is more effective than ERT. It is widely available in South Asia. Survival has improved, and certainly I feel, again, this is just a personal opinion, it may be a more appropriate intervention when ERT is not available. So what are the challenges to healthcare? Well, many of you are familiar with these challenges, and I'll just briefly mention them. It's a very poorly funded public sector. There's a low literacy rate, geographical constraints leading to long distances to travel, with poor access to healthcare, especially in remote areas. Traditional beliefs can sometimes hold sway. There may be ethnic discrimination, and we see the effect of natural disasters. For example, the 2004 tsunami in Sri Lanka, or the 2015 earthquake in Nepal. Now, so these, the following slides really apply to what we can do in countries in South Asia. So we need an LSD team. Obviously, we have doctors, nurses, psychologists, physiotherapists, a dysphagia speech and language therapist. Sorry, I wrote physiotherapist again. Biochemist. It's very important that the biochemist be an integral part of the LSD team so that diagnoses are discussed immediately, or the biochemist can tell us about new diagnoses. We talked about the hospital specialties required. And it's very important to set up these multi-specialty clinics. So this is an example of one. This is the one in Chennai. It's always held on a public holiday so that the maximum number of patients can attend, and also that the doctors get the day off. The families are given a specific checklist and notes at registration. They then move between the specified consultants on their checklist with their notes. So they only go to the consultants that are on their checklist. The consultants will examine the patient and write in the notes, and the notes are returned when the clinic is over. This is another approach. This is a video clinic that I participated in Chennai. And as you can see, I've got a, earphones, and I've also got a speaker microphone. There's a technician actually videoing the examination. I'm actually saying what I'm doing. And in the next room, there were about, I think, 30 or 40 clinicians who were able to watch all this on a large screen. And in this way, it minimizes the distress to the families and maximizes the benefit to the clinicians, and really does not require much outlay at all. As you can see, the things have improved, sort of developed dramatically over the last few decades in terms of findings, or cellular findings and treatments, etc. And this sort of information is now easily available to patients. And as a result, they have high expectations with which they come to the clinic. Sadly, the clinicians may not be able to deliver these expectations. And this leads to frustration for everyone. And this has to be managed. So what are the priorities for South Asia? Again, these are just my views. There needs to be good postgraduate genetics training, raising awareness through CMEs, a small number of specialist centers working together, national networks that link with international ones, close collaboration with the labs that should be fully accredited, and managing expectations, and emphasizing the importance to patients and families of non-specific management, that there are things we can do for their children that don't involve, even if treatment is not available. So, my conclusions, clinical awareness at all levels needs improving. Early referral to specialist centers is vital. A basic knowledge of what tests to request prior to referral saves valuable time, and non-specific management needs to be better organized and coordinated. So I'll just list the CME objectives again. I hope you feel that they've been covered adequately. I'm sorry I've not been able to go in great detail on any of them, but I look forward to questions. Thank you.
Thank you very much, Dr. Vellodi. It was extremely informative and an excellent talk, and you covered all the important aspects of lysosomal storage disorders, emphasizing on the clinical diagnosis, taking clues from very, very subtle findings which we find on examination, and you very, very clearly emphasize the priorities and the needs for South Asia. You have a couple of questions, and I think, Suyog, we have time to take them. Suyog, do we have time to take them?
Yes, I think we can go ahead with the questions.
Okay, right. Okay. So I'll begin. I have copied them from the Q&A. So, Dr. Vellodi, 3 questions from Dr. Radharama Devi, who is a very well-known clinical geneticist in India. So she has 3 questions for you. First question is, do splenectomized Gaucher patients on enzyme replacement therapy are at high risk for avascular necrosis and hip fracture? And in this situation, is surgery useful? This is her first question.
Okay, so that question really has 2 parts. The key is the starting ERT before the first bony episode. The impact, the effect of ERT on the bones is far better before any episodes of avascular necrosis. Once avascular necrosis episodes have set in, ERT is far less effective. I think that answers that question. So it's the interval between the onset of ERT and the occurrence of the first episode that is absolutely critical. Yes, surgery is certainly feasible, and there's been a lot written about surgery, and I should say I'm not a specialist orthopedic surgeon, but there are various approaches that are certainly available.
Okay. So the second question is that what is your opinion on umbilical cord stem cell therapy in Gaucher? And do these patients require immune suppression or no if you are using cord blood stem cells?
Yeah, so cord blood cell therapy has advantages in that engraftment is easier, but immunosuppression is still required. It does take longer to recover, though.
Yeah.
So, yeah.
Okay, thank you. And the third question which she has is that how can Indian patients with MPS 3 have access to gene therapy trials? So
That I don't know the answer
difficult
to. I'm
one.
sorry.
Okay, right. Okay, so another question, I didn't get the name. So again, something similar to Dr. Radha Ramadevi's question. So how can the Indian patients be enrolled in research, particularly in therapeutics outside India? So that's another question from someone who has not specified the name.
Well, there's lots of advantages to India. I think these should be highlighted. And this also may be the case in other South Asian countries. English is widely spoken. Certainly in India, there is a good network of physicians. So there is who are experienced in managing LSD. So there's a good infrastructure. And this is attractive to pharmaceutical companies. But particularly the fact that English is widely spoken, I think this is really helpful. Also, but in terms of access, I think that's really down to the clinicians in India and other countries to ensure that they are in touch with pharmaceutical companies from an early stage. They put forward their case vigorously, champion their patients. This is all down to the clinicians.
That's right, sir. Okay, so one interesting question for you from Niharika. She wants to know, do we have some tests to differentiate between types of Gaucher disease, type 1, 2, and 3? Or it's clinical?
So the diagnosis, the biochemical diagnosis of Gaucher disease does not distinguish between the types. In other words, the enzyme deficiency will not distinguish between the types. Molecular tests may help. Certain mutations are seen more commonly in type 1 than type 2 and type 3, etc. But this is not sufficiently reliable to make a clinical diagnosis. So these are type 1, 2, and 3 are essentially clinical diagnoses, and the diagnosis has to be made clinically. There's no option.
Okay, thank you. So now we have 3 questions from Dr. Sanyal. One question, what he has asked is how the cost for these expensive treatment be brought down?
Yes, as you can guess, I don't have an answer to that. I think that it's disappointing that more has not been done in India in the field of biosimilar and generic drugs. It's not that straightforward. Actually, engineering these drugs is quite complex. These are complex molecules. Also, biosimilars also require clinical trials. They may only require a phase 3 trial, but they still requires a trial, whereas a generic drug does not. That's the difference. So I think that companies perhaps are put off by the need to conduct clinical trials with biosimilars. With other conditions, there's no problem. There are enough patients. But how else cost can be brought down? I can't tell you.
Yeah, so actually there was another question on biosimilars from Dr. Bhavna, and she wants to know, you said that in India not much work is going on in this area, particularly for lysosomal storage disorders. She wants to know anywhere else in South Asia this is being done, work on biosimilars?
No, not
that's
as far as I know.
Question. Yeah.
In fact, the only biosimilar I'm aware of that's been developed in LSDs is in Fabry disease. I'm pretty sure there's only one that's been developed, and that's not in South Asia.
Okay. So as I said, Dr. Sanyal seems to be dealing with adult patients, and he wants to know that he very often gets borderline enzyme activities in patients where he suspects various LSDs. So how to deal with these patients?
Well, I think the first thing is to ensure that the enzyme assay has been done in a recognized lab. I have the only condition, the only LSD in which you can get borderline levels is Fabry disease. And that's why molecular diagnosis is essential in Fabry disease. In all other LSDs, to the best of my experience, I've never seen a borderline result unless it was done in a laboratory that didn't have experience and was not accredited.
Okay. He has asked another question. To what extent enzyme replacement therapy helps if the patient with Fabry disease is already in advanced stage of chronic kidney disease?
Yeah, well, so Fabry disease, so the kidney can be replaced. So if the patient undergoes a renal transplant, it is well known that Fabry disease does not recur in the transplanted kidney. So as long as the other systems, the heart, stroke, or as long as the patient is otherwise reasonably stable, there's no reason why he couldn't have a renal transplant and have ERT.
Right. He has another interesting question that he may be seeing patients with renal involvement, and these patients may have coexisting morbidities like diabetes and others. So he's asking if there are any clues in situations where these comorbidities are also there and there is CKD. So in this situation, can we still suspect Fabry disease?
That's a very good question. So I had a patient some years ago. Well, actually, the patient was a child. It was an asymptomatic boy. The mother had presented with SLE.
Okay.
And obviously had the renal complications of SLE, which overlap with those of Fabry. But they looked at the biopsy and thought there was some storage and found the enzyme activity didn't help.
Mm-hmm.
And they found a variant of uncertain significance.
Mm-hmm.
So this was what I was referring to. This was a typical case. And what we had to do was the Darylyn Hughes team at the Royal Free Hospital carried out expression studies.
Okay, right.
And based on that, it was determined that this was in fact Fabry.
Mm-hmm.
So yes, so that's what I meant. When you see a variant of uncertain significance, further testing may be required.
That's right. So that's interesting. So we have one question from Dr. Mamta Muranjan, again, very well-known clinical geneticist from Mumbai. So she wants to know your opinion about enzyme assay on dried blood spots when we are talking of LSDs.
I think that it's highly desirable in India. Again, it's very important to make sure that I think it boils down to the laboratory. And I haven't touched on this aspect, but laboratory testing in South Asia, we need to ensure that it is of a very high standard, meeting certain international qualifications and requirements. And it's the same as with a blood sample. If you send it to an inexperienced laboratory, you will get the wrong answer. There has been quite a lot published on DBS in LSDs, and there are a number of panels that have been set up. So yes, and certainly given the environmental conditions in South Asia, it is a very good idea.
Okay, thank you. So we have many comments for everybody has commented on your wonderful talk, and somebody who's not specified his or her name is mentioning to your recent paper on the neonopathic Gaucher disease, the definition. So very nice paper indeed. So So wonderful talk again, Dr. Vellodi,
Thank you.
and we had very nice interactions, very, very interesting questions. I
Yes,
think a
really.
recent
Thank
one
you.
has come up again, so let me just see if there is any new one. So Sheila is there and she's probably wanting to ask a question. Maybe she'll type it now. Sheila, can you type it if you have a specific question? Okay, she has sent the question. So classic male Fabry patient on ERT, if he is getting recurrent stroke, what can be the approach?
Yeah, that is very difficult.
Difficult.
Very difficult. I mean, there is, unfortunately, the treatments that are available for stroke are not that effective in Fabry. It should be one of the things in Fabry stroke. We have to understand that it is. So normally, say atherosclerotic stroke, it is related to reduced blood flow. In Fabry, it is actually increased blood flow.
Mhm.
So if you do a scan, whatever scan, you will find increased blood flow, and then on treatment, the blood flow reduces. So it's not the same as a atherogenic stroke, and the approach is different. And I don't know of any treatment that's really that effective. It's really early diagnosis and prevention, I think.
Yeah. So Dr. Sheila Namputri is she's from Cochin, and she is a very well-known clinical geneticist again, and she has recently published a paper on Fabry, the patients from India. So right. So I can't see any more questions. So Suyog, would you like to wind up, or would you like to give some comments? Or Tanya wants to say something. I don't know if she has logged in. Tanya, would you like to give some comments, or Suyog?
So I would just like to, briefly apprise the audience about the International Gaucher Alliance,
Okay,
and I
so
would
you have
like
a video,
to play a small video
small
about
video.
the IGA, which will give deeper insights to the audience about the work of the IGA, what it does, and how it helps the patients all over the world to lead a better life. So I just share my screen now.
Impossible is just a big word thrown around by small men who find it easier. Impossible is just a big word thrown around by small men who find it easier to live in the world they've been given than to explore the power they have to change it. Impossible is not a fact. It's an opinion. Impossible is not a declaration. It's a dare. Impossible is potential. Impossible is temporary. Impossible is nothing.
The European Gaucher Alliance is a pan-European umbrella group representing the interest of Gaucher patients and patient groups throughout the world. Gaucher disease is very rare, but the most common lysosomal storage disorder caused by a deficiency of a specific enzyme. Each disease course can be different, ranging from non-visible symptoms to severe disability and death. Our success is based on the close cooperation with both the scientists and clinicians, as well as the industry. This is essential to fulfill the overall mission, which is to improve quality of life of patients and their families, with the aim to ensure that appropriate treatment is available to all patients.
At the first meeting in 1994 of the European Working Group on Gaucher Disease, the EWGGD, patient representatives were invited to attend. Encouraged by the clinicians and doctors, patient representatives continued to attend the EWGGD. During these meetings, they recognized that they needed more time to discuss the patient needs as well. This marked the unofficial founding of the EGA. In the year 2000, a separate day for a meeting was held alongside the EWGGD in Jerusalem. Thereafter, at EWGGD meetings in Prague, Barcelona, Cambridge, Budapest, Cologne and Paris, the EGA have held their own separate meetings to discuss issues of common interest. At each meeting, more and more local patient groups became members. At this time, the EGA began to realize that it needed to become a legal entity. In 2006, a working group was set up to prepare the foundation of a formal organization. At the EWGGD meeting in June 2008, the official EGA was born. The EGA has since become an incorporated limited company registered in England. From the very beginning, the EGA has been reactive and has responded to the requests for help made by patient groups to support and guide them. The proactive development of new patient groups in different countries, even outside the EU, has produced the great result of 43 member associations. The EGA's work has led to activities on a wider global remit to better serve the needs of the global Gaucher community, with an umbrella group to support them and ultimately the Gaucher patients. As the EGA footprint expands across the globe, we're becoming aware of the challenges in many parts of the world.
Support to patients that don't have access to treatment is a huge part of the EGA's work. Despite the fact that we have 3 enzyme replacement therapies and 2 substrate reduction therapies licensed for Gaucher's disease, there are still hundreds of patients globally that are unable to access these high-cost drugs. The EGA receives requests from desperate patients, parents and doctors asking for help. We send these requests to the companies, and then we work with these companies to see if the patients can get access to treatment through the company charitable access programs. We also link patients with other patients in their countries, and where this is not possible, we will continue to support these patients and their families emotionally so that they don't feel alone, and continue to work with the companies to find alternative solutions.
I've been working for EGA for more than 10 years now, and during this time I've seen how much the EGA has done for Gaucher patients. EGA has helped a big number of Gaucher patients all over the world, and I am very proud that I can be a part of EGA, improving the lives of Gaucher patients directly and every day.
My motivation for working for the EGA is because I'm a mum. My daughter Madeline was diagnosed when she was 17 months old with neuronopathic Gaucher's disease, and I felt very alone. And since then I've been working in the Gaucher community to make sure that no family who receives a diagnosis ever feels alone.
I'm here working with the EGA because I'm a Gaucher patient myself. I have the capacity to make a difference for Gaucher patients around the world. And I'm here for Maria. I met her when she was a very sick young girl, and now she's a beautiful young lady, and I like to say that I've been a part of her journey.
My motivation to work for the EGA is in first line to connect people together, and especially organizations who are living isolated and who are not benefiting from such a network as the EGA does. And therefore, these organizations have the opportunity to help their patients with the aim to make a better world for Gaucher patients.
My wish is that it grows in just the way it needs to grow. It's there to serve, and it belongs to the patients, and it will continue to meet the needs of the patients, and that's my wish. is that it continues to provide what's necessary.
Gaucher disease and its treatment has come a long way in the last 2 decades with the advent of and development of enzyme replacement therapy in particular. However, there are still a lot of unmet challenges.
It is a very exciting time with extraordinary possibilities for patients, but it's also very challenging times in terms of how the health payers view treatment of Gaucher disease.
The status quo of Gaucher disease is a continuing dynamic equilibrium with more and more to do, more and more to understand, more and more we need to relieve actually in terms of suffering. What I've learned is that if you want to do something in a difficult disease, you need 3 parties. You need the clever scientists and doctors who are going to do things, but they can't possibly do it on their own. You need the industry who wants to do it from a financial platform of investment. But in the end, you always have to take the patients along with you, and they, in the end, often write the agenda and do the critical thing that makes it happen.
So what can you do to help the EGA meet its aims and objectives? Please participate in our work. Volunteer for standing on the board or to work on with one of our working groups. Please help us raise funds, help us raise awareness for Gaucher disease through International Gaucher Day or other activities locally. Participate in meetings. Please play your part in helping make the world a better place for Gaucher patients.
European Gaucher Alliance, driven by passion for patients.
Okay, thank you, Suyog, for this beautiful video. And in the end, I would again like to thank Dr. Ashok Vellodi for his wonderful presentation, the IGA and Sanofi Genzyme for organizing this, and all the participants, which is the most important thing for participating in this CME and sending very, very important and relevant questions, and for a very, very interactive session. And I would again like to thank IGA for involving me in the moderation of this particular session. Thank you very much.
Thank you everyone for joining us today, and also particular thanks to Dr. Vellodi for sharing his wonderful insights. Thank you so much.
Thank you very much. Thank you.
Thank you.